Good evening, everybody. We're going to start on chapter 26 of your book. It's relatively short. We're going to discuss the aging individual, some various theories of aging this chapter goes through, and some common causes of psychopathology, as well as a few other thoughts and ideas related to aging. Growing old, as we know, is not a real popular thing today. We do know, however, that a lot of the baby boomers will reach their 65th birthday by the year 2030. This means that with what we do, there's going to be more and more of a need for care for those who are elderly. And for the most part, in the various areas of nursing, we are going to care for the elderly, with the exception of pediatrics and maybe OB in the medical, surgical, and ICU areas or acute care. A lot of, if not a majority of our patients are going to be the elderly. So we really do need to check out our own biases and feelings about aging and deal with it and realize the special needs of this population. How old is old? That's something for us all to decide, but really taking into consideration we once did not live very long at all. In the prehistoric ages, in the 30s and 40s, where the prehistoric ancestors, as your PowerPoint is saying, probably had a lifespan of 40 years, but the average lifespan was only about 18 years of age. And when you think of things such as the wild animals and dinosaurs and things like that, and not having the care that we have today, folks died, at very young ages. The average life expectancy for a child born today is approximately about 76.2 years for males and 81 years for females. There are a lot of myths and stereotyping related to the elderly in our culture today, unfortunately. So how old is old? This is determined, by ourselves. And this, if we look into our gunny sack, we know that what influences us as well as our patients is how we grew up. Who were those elderly around us? Have we been exposed to maybe deaths of loved ones that were unfortunately very pain-filled and such? Do we have grandparents, or have we had grandparents that worked till late ages and drive and will continue to drive and continue to be healthy? All these things, as well as our society influence our ideas of what is old. So in 2010, Americans 65 years of age or older numbered 40.4 million. That represents about 13.1, and it's speculated by the year 2030 that this will be up to about 72 million, or 20% of the population. You see here the marital status: 72% of males and 42% of women are married. There are over 4 times as many widows as widowers. Living arrangements: the majority of individuals, older individuals, live alone with a spouse or with relatives. Most of them at this point are not out in long-term care. Really, it's quite expensive. Economic status: approximately 3.5 million persons older were greater than 65 years of age were below the poverty level, and many of these folks that you're going to care for and receive orders from their from their healthcare providers, sometimes have to make the decision: do I buy food this month, my medication, or what is it, that I can afford this month? And so sometimes compliancy is related to their level of economic level. Employment: a lot of those that are 65 years or older are still in the labor force and cannot retire and get out and still make it. Health status, the number of days in which usual activities are restricted because of illness or injury increases, we know, with age. And with age, there's increased comorbidities. Emotional and mental illnesses also increase over the life cycle. There are several theories of aging here, several biological on this PowerPoint. The first one is genetic theory, and this one goes into aging being an involuntary process, and that over time our cellular and tissue structures, you know, wear out over time. It suggests that lifespan and longevity changes are predetermined. Wear and tear theory states that the body wears out on a scheduled basis, and free radicals, which are the waste products of metabolism, accumulate and cause damage. The environmental theory, these are factors such as pollution, sunlight, trauma, bring about changes in aging process or speeding up the aging process. The immunity theory, that we know there's a decline in our immune system, and so we become more susceptible to disease. Our immune system, for example, is the number one sentry on guard for things such as cancer, not only contagions, but the more our cells produce, the more and reproduce, the more likely that we are going to have cancer, and our immune system is the number one guard who weeds out cancerous cells. But as our immune system declines, we are more likely to develop cancer as well as other disease processes. The neuroendocrine theory states that aging occurs because of the lack of hormones. Psychosocial theories, we see up here several, 5 of them. As far as personality, really there are no specific changes in personality that are noted with aging. Developmental task theory states that older folks who have lived with integrity and developed along the way are much happier. The disengagement theory, this is the process of withdrawing from life, from societal roles and responsibility, and this is very predictable and systematic and necessary to proper functioning of a growing society, and we see that all the time. As we age, we give up, a lot of our responsibilities, one by one, and kind of pull into ourselves and hopefully enjoy some of that time of retirement and such. The activity theory, it really focuses on aging healthy and staying as active as possible. And the last psychosocial theory up here, the continuity theory, this goes into coping abilities and personal character traits, and these help predict how well a person will adapt to change and aging. Here's a question up here. Which statement describes a theory of aging from a biological perspective? A, personality traits change gradually but systematically. B, staying active leads to satisfactory aging. C, lifespan and longevity are predetermined by heredity. D, old values take on new meanings in keeping with changing circumstances. So what's the answer here? The answer here is C, and this is genetic theory. According to genetic theory, aging is an involuntary inherited process that operates over time to alter cellular or tissue structures. And this biological theory suggests that lifespan and longevity are predetermined. The normal aging process, and you guys, when you went through Med-Surg 1, you had lectures from our dear director of nursing. And this, right here, biological is telling you the different changes in our body. And so you know that there's changes in everything, and you can read this PowerPoint from the start, it goes into skin and it loses elasticity. And you can see the very last one is sensory system. So we have changes in every system as we age. Psychological aspects of aging, memory functioning. Short-term memory does seem to deteriorate with age, but long-term memory doesn't show similar changes. Really with normal short-term memory, we do notice it takes longer to kind of scan through the files of our brain to pull out recent and remote recall as we age. And over time, we learn more and more, and so there are more files there to scan in our brain. Mentally active people do show less memory decline. The more they use their brain, the more they take classes, the more they converse and entertain themselves, they do show less memory decline. Intellectual functioning doesn't change in the elderly. They just sometimes do not use it as much, and that's kind of the idea of it becoming obsolete in some folks. Now, it does depend on how long ago they were educated and what their educational experiences were. This is reflected in, as your PowerPoint's saying, their scoring. Learning ability, we're able to learn throughout life. As we age, sometimes it takes an older person a little bit longer to learn, but we seem to hold on to it longer than someone younger. We have history, we have life experiences to connect with these learning situations. All right. Adaptation to the task of aging. Loss and grief are big as we age, our friends and such. And I remember my grandmother, who, as you guys know, was my mentor, Alice. She lived to be 91. In her last 2 years of living, she was diagnosed with vascular dementia, but before she was up till when she was 89, and then it started showing deterioration. She had pretty much she had lost all of her family members as far as her sisters and brothers and such, and pretty much all of her friends, of course, that were near her age. And bereavement overload, as you can see, it's the third item up here in your PowerPoint, is hard because no sooner do they lose one person than they lose another. And sometimes they become quite depressed because they don't have a chance to get through one loss and grieve that loss before they have another one. So mourning almost seems to become a lifelong process due to these losses. Attachment to others. It does help the well-being of seniors to get out. I mean, all of us, but especially seniors as they retire and such, they need to get out and socialize. They need more, buffers. They need that coping base to stay broad to help them through the stressful events, just like everyone else. Now that many of them may not be working, they need to reach out more and expand and make sure they have folks to talk with and assist them. Maintenance of self-identity. This is really important as they go through retirement, and many of us, a part of our identity, it's so huge, is what we do. You all who are becoming nurses, myself as a nurse, once we retire and get out of that, it's difficult because that's a big part of our self-identity. Some of the factors that have been shown to favor good psychosocial adjustment, family relationships, maturity of their ego defenses, absence of comorbidities, absence of alcoholism and depressive disorder and such. Dealing with death. Studies show that for the most part, majority of elderly people do not feel death itself, but they fear being alone, being in pain, losing their mind, and memories. Death anxiety among the aging is apparently more of a myth than a reality. It is more of that loneliness and such, though. They fear being alone. Psychiatric disorders that frequently happen, excuse me, as we age. Neurocognitive disorders we see, and this is supposed to be one of the big deals related to especially Alzheimer's and some dementias related to free radicals or toxins that build up in our system. Dementia, and we're going to be talking about that in one of the lectures coming up, the different types of dementia. Delirium, some of the causes of delirium, and we're going to, in a lecture coming up, compare dementia and delirium, but delirium happens with multiple medications, which many elderly folks are on, substance abuse. It can happen from septicemia, and we know our elderly folks get a lot of UTIs, and when they do, it is sometimes not diagnosed till they are septic because of the immune system being more depressed. Depression, schizophrenia, we know schizophrenia is a chronic condition as well. Anxiety disorders, personality disorders, and sleep disorders are common in later life. Elderly people in virtually all cultures share some basic needs and interests. They want to hold on to their integrity, to have a satisfying life. They want to be able to make choices and participate in all aspects of their life. They want to be given loving care and be protected. And, dying with dignity and respect is very, very important. In some cultures, the aged are the most powerful. And we've talked in this class, and you have also reviewed some of the different cultures and fundamentals as well as throughout your education with us and other education you've had. For instance, the Asian Americans, the aged are the most powerful and most respected. In some cases, this isn't so important. In the American culture, we see that a lot. And some of the other cultures, as well as the Asians that value the older individuals, or the Latinos, and the African Americans. Sexual aspects of aging, and I always say this, and I'll say this again, when I was trained for my nurse practitioner career, and we talked about sexuality and those who we should screen for STDs. We never thought of our older patients, and really sexuality in healthy individuals could go on till the end of our life. But today, one special aspect of this as well is we do have some abilities have been increased due to medication such as Viagra and such there. So we do have to remember safety of sexuality. We also need to look in our gunny sacks and be careful of not judging the elderly. I've worked in long-term care home where an important aspect of dignity and safety was providing a private area. We would have couples who would share, a room, or couples who were competent who, needed to have privacy to express themselves sexually. And that is something that we should consider as nurses as well. That is a right in those who are competent. Cultural stereotypes do play a large part in our misperception of elderly people and sexuality. Physical changes with sexuality. We know in us women there is a big decline in fertility and ovarian function. And with reduced hormones such as estrogen, there are problems such as vaginal dryness and menopausal symptoms. And some women take hormonal replacement therapies. And we're going to be talking in MedSurg 2 for those of you who will be coming or having to take that class, which is most of you except for our paramedic students to RN. We'll talk about hormonal replacement therapy more. Changes in males, their hormones decrease. Many of them have erectile dysfunction, and this happens in a large part due to comorbidities such as hypertension, and diabetes is a big one. And we know that we do have increased medications to help related to this, but there are numerous categories of medication such as the antihypertensives, which do add to erectile dysfunction. Males as females are reproductive organs decrease. In males, we have, or no exception, testicular size, um, and they have a decrease in amount of ejaculate and viable. They, however, do have viable sperm well into their old age. Retirement is important, and relationships. If a couple has been married for a long period of time and their life has all been about their work and not relationship, many of them have difficulty with relationships going on. Social implications, with retirement, they've defined other things that keep them occupied. They might not, due to economical restraints, be able to do the traveling they talked about. Things have become so expensive. Long-term care, many of our insurance policies, we have abilities now to pay for long-term care, but it is very expensive. As we go on, I have shared about my mom and her stories, and she is in long-term care, and she is not at one of the most expensive, but for instance, in 2016, her nursing home is $10,000 a month, and that does not include medications and things. So most of us cannot afford to stay in long-term care if we need 24-hour care. But needing that care increases with age and comorbidities, our mental health status and cognition, if we have dementia, which that's what my mother has. Marital status and living arrangements and informal support networks all influence the need for health. A lot of elderly folks are opposed to the use of institutions, and I've worked with folks that once they enter them, they seem to give up, some of them, and die. So it is important, if we're working in these areas, that we get to know our patients, we encourage them to make friends and go to activities and keep busy. Elder abuse is high, and thinking about the money it does take to put somebody or have them get the care needed in long-term care. Many folks can't afford that, as we said, and so a lot are taken care of in homes. That young couples still have many children, many stresses related to money, and now they have another mouth to feed, and so it's a perfect setup for abuse. And so we have to, as nurses, keep alert to signs and symptoms, of abuse, like injuries to our loved ones or injuries to the elderly, stories that just don't fit, elderly that are fearful. So here's some of those other factors to abuse. Now that they do live much longer, as they live longer, if they're in their 90s and so on, it is much more likely they're going to need a lot of care. Learned violence, they could have, family members could have been brought up with violence in the home, and now their loved one is living with them that was engaged in the violence, and there might be that retaliation. So there are many reasons that abuse happen. We have to be very open-minded and very intent on reporting if we feel anything's going on. Suicide in the elderly, person 65 years of age and older, represent a very high percentage of individuals who commit suicide. More than 15% of all suicides are committed by this age group. Any thought, any statement, we have to take very serious in any group, in any age group. The group at highest risk as far as the elderly are Caucasian males who are lonely, have financial problems, physical illness, loss, and or depression. This is our nursing process, and most of the time in every PowerPoint we go through our care plan, our thought process related to caring for these individuals. And I usually, I'm not going to read every one of these pages, but I would like you to review those and think about them. Some of our diagnoses. Question. An elderly client newly admitted to a nursing home refuses to participate in activities of daily living. Which nursing intervention would best help the client to be as independent as possible in meeting self-care needs? Assign a variety of caregivers. B. Establish a specified amount of time for ADL completion. C. Set client expectations at the beginning of each day. D. Structure the activities of daily living to mirror previous home routine. D is the answer here. I've worked with folks who, we want them to get them to participate as much as possible. This adds to their emotional health when they feel in control, even of the smallest things in their life. And helping them to feel comfortable. I mean, if they were somebody who worked 11 to 7 their whole life, they might be that person who's up at night watching TV quietly in their room and not preferring to take their shower in the wee morning hours. So it is, this is their home, especially when they go into long-term care or we come into their home to help them in home care. It is important that we encourage this adjustment and work with their familiar routines. Which therapy is most effective in decreasing depression in elderly clients? You may have read about this in your chapter. Crisis intervention. Crisis intervention would be something that would take place during a crisis, but we want to decrease depression in elderly. B. Group therapy. C. Orientation. D. Reminiscence. Reminiscence is pretty cool. And over at Matter Care, we see some of this, and this is where they encourage the patients and clients to think about and reflect on the past. They might play games with them on current events or past events, helping them to recall events in their life that they remember. We pull out the newspaper there, we play games and help them with familiar holidays and stars, and they kind of increases their self-esteem when they find they can remember and participate with others. It helps older folks to work through losses and maintain self-esteem. This is the end of our chapter 26. It was a short one. I will talk to you all soon. Thanks for your attention.